Here we go. So I just need to get one more window up here and I should be good to go. So I believe if there's any challenges with the audio or being able to see the screen, please let me know in the chat box and I will keep that up so that I should be able to still see that. All right. Okay. Let me just grab some water. And we may still have some folks joining us, but I think it is time, 12:01. And we have definitely a full hour webinar for you here today. Welcome. Thanks for being here. My name is Kara Kaikini, and I'm the breastfeeding consultant for Maine's Perinatal Outreach Education and Consultation Services Program. And I'm here today to talk with you about prenatal breastfeeding education, conversational approaches, and essential topics. And I know that there are many of you from lots of different areas of the prenatal education world, and beyond. So I really look forward to learning from you toward the end as well. So be prepared to share a bit about what works for you, what takeaways you may have, anything else that you would like to share with those of us who are on the webinar. It sounds like you won't be able to be unmuted, but you can certainly type into the chat box and I will be able to read those out. All right, so I have no disclosures. All the planners, faculty, and others in control of the content of this webinar have no relevant financial relationships. And our learning objectives for today are to describe the evidence showing the impact of prenatal education on breastfeeding rates, to educate others on 3 breastfeeding related topics like pumping, marijuana use, and milk supply, to be able to differentiate between ineffective and effective education techniques, and to identify additional breastfeeding education resources for patients and providers. So let's start with a quick overview of what the health organizations recommend for prenatal education based on the evidence. So first, the American College of Obstetricians and Gynecologists recommend in their committee opinion about optimizing support for breastfeeding that OBGYNs should discuss breastfeeding with women, and that since lactation is an integral part of reproductive physiology, all obstetrician gynecologists and other obstetric care providers should develop and maintain skills in anticipatory guidance, support for normal breastfeeding physiology, and management of common complications of lactation. So anticipatory guidance. Those of you who are providing education in the hospital are doing this throughout the postpartum stay. In particular, you are offering a lot of education about baby care and breastfeeding. And how many moms have you met who had expectations that breastfeeding would be really easy and that all she had to do was put the baby to her breast and the baby would breastfeed? And how does she feel when it isn't that easy and her baby wants to nurse every hour? Preventing this surprise and disappointment is so appreciated by those postpartum nurses and lactation consultants. And the more education we can offer prenatally before they are sore and tired and flooded with hormones and in non-pandemic times, busy with visitors, the better. So the Journal of the Academy of Nutrition and Dietetics found that mothers who believed their healthcare providers preferred breastfeeding only were least likely not to initiate breastfeeding. Or in other words, these mothers were more likely to initiate breastfeeding. And mothers whose infants' doctors preferred both breast and formula feeding were 2.7 times more likely to never initiate breastfeeding. Whereas mothers whose infants' doctors didn't have an opinion, or it wasn't clear what their preference was, they were almost 2 times as likely not to initiate breastfeeding. The impact of the father and grandmother's perceptions were also significant factors in whether the mother initiated breastfeeding. And their analysis suggested that the opinions of family members and healthcare providers play an important role in the woman's decision to breastfeed. And that during the prenatal period, healthcare providers have an opportunity to communicate the importance of breastfeeding. And they also found that prenatal education, including the father and the maternal grandmother, and professional training for healthcare providers are needed to improve breastfeeding initiation rates. And so that's why we're here, that's why I'm here, is to help provide that education so that it makes your job a little bit easier too. In 2013, the CDC released the Guide to Strategies to Support Breastfeeding Mothers and Babies, and Strategy 7 is to increase access to breastfeeding education and information. And they suggest breastfeeding education should be taught by someone with expertise or training in lactation management and can be offered in a variety of environments. And they state the goals of breastfeeding education are to increase mothers' knowledge and skills, help them with breastfeeding, view breastfeeding as normal, and help them develop positive attitudes toward breastfeeding. The information they recommend offering during the prenatal period includes anticipatory guidance, benefits of breastfeeding, information about positioning and latch, understanding the early days of breastfeeding, offering resources, and addressing common fears, concerns, problems, and myths. And this CDC guide shares evidence supporting this recommendation. A 2008 review by the US Preventative Services Task Force found formal breastfeeding education alone to be ineffective in increasing rates of breastfeeding initiation or duration. However, when used as part of a multi-component intervention, both prenatal and postnatal education had an effect on short-term exclusive breastfeeding and the duration of any breastfeeding. So multi-component intervention is what's most effective. A Cochrane review of 5 studies that involved primarily low-income women, education resulted in a significant increase in the number of women who initiated breastfeeding. And a subgroup analysis found that education was especially effective if it was personalized for each woman's needs, and that makes sense. There's a lot of research supporting that, as we'll talk about. An earlier 2003 review by the US Preventative Services Task Force found that the use of printed breastfeeding information alone, such as pamphlets, books, posters, had no effect on breastfeeding initiation or duration in the short term. However, printed materials are often used as a component of multifaceted breastfeeding intervention. So again, it's a part of a multi-component education. So in summary, any one method or form of education is rarely sufficient. The World Health Organization and UNICEF, the 2 organizations who created the Baby Friendly Hospital Initiative, recommend antenatal care as one of the integral steps to supporting successful breastfeeding. And this includes discussing the importance of breastfeeding and preparing them and how to feed their baby. The most thorough and evidence-based recommendations on prenatal breastfeeding education comes from the Baby Friendly Hospital Initiative. And step 3 is to inform all pregnant women about the benefits and management of breastfeeding. They suggest that education should be made available to pregnant women through their own clinics or services, or through fostering relationships and coordinating with community programs. So if a hospital doesn't have its own clinic or its own services that might offer a prenatal breastfeeding class, they can still meet the requirements of this step if they coordinate with community programs. They also recommend that it begins in the first trimester whenever possible, and that individual counseling or group education is given to at least 80% of women. So what's important to understand here and notice here is that if patients attend a group prenatal class, this is likely sufficient to meet the step, as those classes cover most, if not all, of the topics required by this step, which we'll get to in a moment. And if there's not a prenatal class available, like I said, at the hospital, working with community programs like WIC or Maine Families could help meet that step, since they probably utilize a curriculum that would meet those requirements. This Academy of Breastfeeding protocol makes several recommendations about how to best provide breastfeeding education in the prenatal setting. First, they recommend creating a breastfeeding-friendly office and community. That's always helpful. Consider the background, ethnicity, and culture of individual women, families, and communities. Consider behavioral and psychoeducational approaches. Integrate breastfeeding promotion, education, and support throughout prenatal care. Take a detailed breastfeeding history as part of the prenatal history. I think that is really appreciated for those of you who are working with moms postnatally in the clinical setting, wanting to make sure that there's a detailed history, and also assessment. So incorporating breastfeeding as an important component of the initial prenatal breast assessment. So if prenatal breast assessments aren't happening, it is highly encouraged by the Academy of Breastfeeding Medicine and other groups. This document also breaks down what to discuss at each trimester. This will be referenced at the end of the presentation that you'll have access to later. So now let's talk about what kind of education is most effective. First, let's get to the reality of prenatal education. So some of you are home visitors, some are WIC peer counselors, some of you are nurses in OB offices or nursing school. I noticed some new registrations come through from nursing school, or some of you are in the hospital, maybe you're a midwife, maybe you're a doula, and each role is so important when it comes to offering prenatal breastfeeding education to expectant parents. And as different as some of these roles are, they probably share challenges. So I did come up with some challenges that I've heard about before. And I would love to hear from you after I review those. What I want to do right now is make sure I have access to that chat box again, just in case I'm missing anything. Okay. So some of the challenges that I am aware of are that you're busy. I mean, everyone's pretty busy, and that is definitely going to conflict with doing as much as you want to do for prenatal education. You have time constraints, especially for those of you that are working in an OB setting prenatally. You may have 15 minutes with a mom, and you may have to be focusing on helping her with any sort of addiction that she may have, or you may need to help her find a meal, her next meal, or some clothes. So there are certainly going to be competing priorities and time constraints, conflicting priorities. And access to technology and materials. Some of the research that I came across showed, it reviewed programs on iPads that were able to be offered to expectant mothers, and not everyone has access to that kind of technology or those materials. So what else? Is there anything else that you can think of? Any challenges in particular to prenatal, offering the prenatal education that you would like to the families you work with? And while I wait, if anyone has anything else they want to offer, I do see your question, Ellen. Is there an assessment document that can be used for the nurses now with COVID and phone visits? So I'm not exactly sure what you're referring to. And Kelly, I don't know if you can keep notes of these questions, and so I can follow up with them after. That would be excellent. I would love to follow up with you after, Ellen, unless something comes to me in the meantime. All right, I'm not seeing any other challenges that you want to share. I may have captured that based on what I'm familiar with. Okay, Ellen, thank you. Partner, and Ellen Kunkel, partner support, people not always being present, and language barriers. Thank you, Jill, absolutely. So those are very valid and real challenges to offering the kind of prenatal education that I know you all want to. And it's always helpful for me to see these things as well. And I'm seeing in the Q&A, there's a whole section, Q&A section as well, preconceived notions from patients. Okay, and so we might talk about that a little bit here. And just since I'm moderating this here, I'm going to ask that you type anything into the chat box instead of the Q&A, just so I can, that's the one I'm going to have visible. Okay, so let's move on here. So in the spring, I sent a survey about prenatal education to both parents and providers, and I received 55 provider responses across 15 counties. And one question I asked was if you could recommend one activity to increase breastfeeding rates and improve mothers' breastfeeding experiences in Maine, what would that be? And a very common response was more prenatal education and one-on-one lactation visits to discuss goals and risk factors, education, what's normal, what to expect. And that's a great example of how that would be the ideal situation, to have one-on-one visits like that to go over all of what we're going to talk about is helpful to go over. Other folks mentioned to encourage mothers to empower themselves to find their own support. Nurse and provider education. And I'm a big believer that accurate patient education can't happen without thorough nurse and provider education. So again, thank you all for being here today. Other responses were cultural and societal acceptance of breastfeeding, paid leave, supportive workplaces, better hospital support and specifically baby-friendly hospitals, and better postpartum support in the offices, more home visits, peer counselors, et cetera. So a number of those I want to mention. Another hat that I wear is as the board president of the Maine State Breastfeeding Coalition, and we are